Hi, good evening, everyone. I'm Dr. Pranav Sheth, Medical Advisor of Sun Pharma. I welcome you all to today's virtual meeting on the highlights of the Day 3 of International Diabetes Federation 2025 conference. We are thrilled to have you join us as we dwell into the key takeaways and groundbreaking discussions from this prestigious event of IDF 2025. The IDF conference is a cornerstone in the field of diabetes research and care, bringing together experts, researchers, and advocates from around the world. This year, this conference once again provides us with invaluable insights and innovative approaches to tackling diabetes. We at Sun Pharma are glad to share most impactful discussions of each day from the IDF conference. We hope this virtual meeting will not only inform you but also inspire you to contribute to the ongoing efforts in diabetes care and research. Having said that, let me take this opportunity to welcome our chairpersons and distinguished speakers for today. Can we have the introduction slides, please? Dr. S. Vijay Bhaskar Reddy, our chairperson for today, consultant endocrinologist and managing director, Vijay Thyroid Diabetes and Endocrine Center, Puducherry, Secretary Endocrine Society of Tamil Nadu and Puducherry, awarded one of the Inspiring Endocrinologists of India Award in 2022 by the Economic Times India, has more than 20 publications in the endocrine journals and 4 book chapters, organizing secretary of Trendo. Such area of interest includes type 2 diabetes, FCPD, thyroid eye diseases. Next slide, please. Another next chairperson for today, Dr. Saket Kant, MD Medicine, DM Endocrinology, Senior Consultant Endocrinologist at Max Super Speciality Hospital, Shalimar Bagh, Pitampura, Action Balaji Hospital and Cancer Institute, Delhi. Sir has completed his MBBS and MD from UCMS Delhi University and DM Endocrinology from IMS Banaras University, Banaras Hindu University, accredited MRCP and fellow of the American College of Endocrinologists. More than 40 papers published in national and international journals. Has been a reviewer and editor of various prestigious journals internationally. Thank you, sir, for joining us. Our first speaker for today, Professor Maria Smith, is a professor, Department of Social Medicine, Federal University of Rio Grande do Sul, Brazil. Is a fellow in pediatric endocrinology at Johns Hopkins Hospital, USA, Masters in and PhD in epidemiology, University of North Carolina, USA. Has described the dawn phenomena as a cause of glycemic instability in diabetes during the in the 70s. Conducted pioneering public health research on diabetes and obesity in Brazil since the 80s, and has authored more than 300 scientific publications, contributed to national and international diabetes guidelines, members of the Lancet Commission on Diabetes, and recipients of various prestigious awards, and has been recognized globally as one of the most influential scientists in her field. Thank you for joining us today. Next speaker for today, Professor Paolo Pozzilli, is the editor-in-chief, Diabetes Metabolism Research and Reviews, has currently serves as a professor of endocrinology at diabetes at Campus Biomedico University of Rome, and is a professor of clinical research in diabetes at Queen Mary University, London, where he has co-leads the international PhD program in integrated biomedical sciences and bioethics. Professor Paolo received his medical degree and specializes in endocrinology and metabolic diseases at Sapienza University from Rome. His primary research focuses on pathogenesis and prevention of type 1 diabetes, spanning from autoimmune mechanisms to clinical trials. He has played a leadership role in several major international studies, and Professor has received various prestigious awards with more than 515 publications indexed in PubMed, and has been recognized globally for his contributions in diabetes research and care. Thank you for joining us today, sir. So now I hand over the session to Dr. S. Vijay Bhaskar Reddy, and then followed by our first speaker for today. I would request Professor Maria to please then continue on her lecture. Thank you, sir.
Thank you, Dr. Pranav. I think it's a great delight for me to moderate this session today along with Dr. Saket. I think we had a wonderful IDF meeting at Bangkok, and the first couple of days we already have got the update, and this is a further update for today about the highlights of IDF. Speaker introduction is already done. I invite Professor Maria Schmidt to take over and present their findings and highlights from the IDF. Over to Professor Maria.
Good evening. I don't think my slides are there, are they?
Not yet, madam, not yet. Yes, yes.
Now?
Yes, but kindly make it full screen and it's all fine. Yeah. Perfect. Thank you so
Please.
much.
Good. Good evening. It's really a pleasure to be here this evening, presenting some highlights from the IDF 2025 meeting in Bangkok. I'm still in Thailand, and I'll be glad to present a few highlights that I selected from this meeting. I can say that the program that was developed was really good. I had an excellent impression of the meeting. Presentations were good, and the audience was enthusiastic. So I was really very pleased with this IDF meeting. I have been to many of them, but I think this was one that I really will remember for a long time. The first highlight that I'm going to bring to you all is a very important one, and it has to do, sorry. And it has to do with the possibility of using the 1 hour plasma glucose during a 75 oral glucose tolerance test as a valid, sensitive, and convenient test to predict type 2 diabetes. This facilitates reaching high-risk groups for diabetes prevention. The evidence for that is that the 1 hour plasma glucose has been shown to predict better type 2 diabetes than even the 2 hour plasma glucose, which we have been used for quite a long time. And of course, much better than the fasting plasma glucose. This study, for instance, shows a sensitivity of 0.84 compared to the other values, like the 2 hour 0.79 and the fasting plasma glucose of 0.75. This study and also another one confirming these values were reported last year when we published this this new position paper from IDF. So I think this was addressed in 2 or 3 sessions during the meeting, and I consider this an important highlight, particularly because this year there are some new guidelines being developed, and they will work around the possibility of using the 1 hour glucose, the 1 hour value during an oral glucose tolerance test. The second highlight, I think I could not leave it out, is the release of the new IDF Atlas. The new IDF Atlas is telling us that we have almost 600 million people living with diabetes in the world. As you can see here in the pink and dark pinks, those countries already have more than 9% of their adults living with diabetes today. And the regions are all affected. The increase is supposed to be of 45% by 2050, and it will hit the worst in Africa and in the Middle East and North Africa regions. These are all already online. You can access them at the IDF page and use this information for all the aspects related to diabetes advocacy. About 20% of all pregnancies are complicated by hyperglycemia, as shown here. And although it varies across regions, it's important and always more than 10% in all regions. The cost is immense, as you can see in this graph. The third highlight I would like to bring has to do with the postpartum period. The postpartum period, in terms of hyperglycemic pregnancy, can be considered perhaps the most important neglected care. And it is widely neglected around the world, even in high-income countries. Some issues are particularly important. For those who are interested in having more detailed information, I recommend reading this article that was mentioned during the IDF sessions. There is an RCT of planning the initial postpartum period. It addresses in detailed information everything that we need for what they call planning the forgotten fourth semester of pregnancy. The first issue that is relevant is the postpartum glucose status reclassification. I've been following the issues of gestational diabetes for many years, and I can say that this is in the guidelines since the very first one that I found, but still it's a very neglected aspect of diabetes care. And what we need to do is at 6 to 8 weeks after delivery, we need to do an oral glucose tolerance test. Those that have diabetes, we must refer for diabetes treatment. Those that have prediabetes, we must consider some type of diabetes prevention. And those that are normal need to do an yearly follow-up. The problem is that we don't get the 100% of the woman to come for the period of 6 to 8 weeks after delivery, because we have many barriers, as described in the scoping review that is down here. But the good news is that we do have interventions that we can use to ameliorate this picture. But even if we do our best with all the interventions possible, it still may take at least a year until we get all women to do the oral glucose tolerance test after pregnancy. So there's an importance that to prioritize early active screening among those that are at high risk. And when I say active screening, we must use all the maneuvers possible to get them so that the most at highest risk actually come early on. And those that are lower risk perhaps come after 6 months or after a year. But we need to make sure that all that the highest risk come early on, because the rate of having diabetes at postpartum or prediabetes is about 5 to 10 times higher among those at a higher risk. So how do we identify them as being at higher risk? We can use clinical scores that are in the literature. They must be based on pregnancy information, like the glucose values during an oral glucose tolerance test, their weight gain, their BMI before pregnancy, and their family history of diabetes. Or we can use a simple information, like if they needed insulin during pregnancy to treat their gestational diabetes. If they did, their risk of developing diabetes early on at postpartum is much higher. The fourth highlight has to do with the fact that we have now evidence that we can prevent type 2 diabetes with low-intensity lifestyle intervention and postpartum among women with gestational diabetes. This is a systematic review that was presented showing that there are 24 clinical trials already doing this assessment, covering about 9,000 women. And the relative risk is 0.76, which means a 25% risk reduction. The important thing I like to highlight here is that if we exclude those studies with high risk of bias, the relative risk becomes lower, only a 20% risk reduction. Similar thing happened with weight gain. Both groups, intervention and control, gain weight, but the weight gain was about 1 kilogram less among those that were intervened with lifestyle intervention. And if we exclude those studies with high risk, we had about between 0.5 and 1 kilogram of difference in weight gain. So to make sure that the evidence is of good quality, we reported these results in terms of the 18 studies that did not have high risk of bias. So that even though we only have a 20% risk reduction, the degree of certainty is a moderate degree of certainty in terms of grade tables. And for weight change, as I already mentioned, is 0.62. So the last highlight I'd like to mention is that we can discuss the diabetes prevention among this movement in terms of when, who, and how. When, it can be done during pregnancy and early pregnancy to prevent gestational diabetes. It can be done after pregnancy, as I already mentioned. It can be done from pregnancy to postpartum, or ideally before pregnancy. There are 2 studies, at least 2 systematic reviews showing the effects of lifestyle intervention when we do early in pregnancy for the prevention of gestational diabetes, showing a relative reduction of 30%. Very few studies occur before pregnancy. Most of them occur in early pregnancy. However, we know that weight gain in adulthood occurs usually before age 35 in the largest amount. So when we are intervening already in pregnancy, a little bit too late. So the ideal is to do it early on before pregnancy. And there is a study that is taking place, I was told by the author that results will be published by 2026, perhaps in our next IDF meeting. It's called the Healthy Study. Now, moving to who should be intervened, we have basically 2 strategies of intervention. One that is very familiar to all of us in the field of diabetes and is intervening those at high risk. This type of intervention strategy intervenes in high-risk people in order to decrease their risk. And the other strategy is a population strategy where the intervention is aimed at the whole population. And then the idea is to shift to the left the risk in the whole population. We are less familiar with this type of strategy in the diabetes field, but the tendency is to increase the use because of its importance and its possibility of complementing very well all the high-risk interventions that we are used to see. And then the last is the how. If I exemplify with the postpartum intervention, as I mentioned, we have a hard time to get all of them to come in the postpartum because all the difficulties that we have, all the barriers that I very briefly mentioned. And it's possible that the whole period of recruiting them may last for 2 years. So we need to begin with very low intensity interventions in the beginning of the postpartum period when they are still breastfeeding, perhaps exclusively breastfeeding. And then if needed, increase the intensity of the lifestyle intervention, not only in terms of weight reduction, but also in terms of augmenting physical activity, and if possible, also using metformin, which by the DPP study has already been shown to be effective among women with gestational diabetes. So these were my highlights. Thank you for listening.
Thank you. Thank you. Now it is okay. Hello. It is my great pleasure to address two issues in my presentation. The issues of the diabetes type 1 around the world. I've always been working type 1 diabetes because I found that type 1 diabetes is a disease that still requires much attention in terms of understanding the pathogenesis and how the disease develops complications over the years. So what I will do, do you see my slides?
Yes, sir.
Yes, sir.
Okay, right. Now, my next slide, I'm going to talk about type 1 diabetes in low-income countries. This is one of the topics I found extremely important, and I tell you why. The EASD and the ADA really do not pay attention to low-income countries in their congresses. And I think that the IDF is the only international association that really pay attention to that. And I was very pleased indeed to spend my time in Bangkok and meeting many people, colleagues, friends, because I think that we should pay more attention to type 1 diabetes in low-income countries. And it is very interesting to say that because we can understand more the pathogenesis of the disease. And I'm going to tell you how that may happen. Now, if we're looking at type 1 diabetes today, there is no question that it is growing fast and can affect anyone. And over the past 30 years, surely the increase in number of people with type 1 tremendously tripled. And then if you look at the expected rates for 2040, we reach 16.4 million of type 1 diabetic patients around the world. Now, what can we say about type 1 diabetes in low-income countries? Because some people may say, well, the type 1 diabetes in this country is very low compared to countries that type 1 diabetes is definitely more prevalent. But I think let's see to discuss some particular aspect first. There is an increase also in low-income and middle-income countries. And therefore, that is an increase that could be due to changing environmental factors. And I've tried to explain this important concept. The incidence has increased significantly, although to a very low prevalence altogether, in underdeveloped countries, especially in sub-Saharan African, Middle East, and North African regions. This trend remains limited in many underdeveloped countries, and there are several parts in the world, as I can show you later on, where data are not available. I was chairing the session on diabetes type 1 in low-income countries, so I had the opportunity to listen to many different positions in terms of understanding how we can deal with this problem that is definitely an unsolved problem. Now, here you have an interesting picture because you can see the incidence per 100,000 person year. And then you can see 5 different colors. Now, these 5 different colors actually show that the lowest incidence, that is 1 to 5 new cases per 100,000 under the age of 15, the classical type 1 diabetes that we know about it, is present in many parts of the world. So there is a low incidence of type 1 diabetes that is still present in several low-income countries. Then if we go to the quartile 2, that is 6 to 16 cases per 100,000 100,000 under the age of 15. And as you can see here, there are countries with this pale pink that include Asia, Southeast Asia, include some countries in Europe. There are some countries in Europe here that you can see with low incidence. And then we have the quartile 3, that is the quartile with dark pink, that include all continental Europe. All continental Europe, and then as you can see, there is the area here, Iran, Iraq, the Saudi Arabia, and all the states in the Middle East show an increase. But the countries with a higher increase and increased prevalence are the UK, the Scandinavian countries, Algeria, and the United States, including Australia. So the thing is, from our perspective of Europeans, why is that in the UK you have such a high incidence compared to continental Europe, where the incidence is very similar, although always on a trend of an increase? I think this is very interesting, because if you look at the GDP of this country, more or less France, Germany, Italy, UK have the same GDP. So it is not a matter of environment, unless you may say that the Scandinavian country also have such a high incidence because you are in the northern part of Europe. But if you look at the States, again, with a high incidence, you see that it's all over the country. So must be something from an immunological and genetic point of view that differ between countries with middle incidence and high incidence. And then if you look at countries that had a low incidence, they tend to have an increase, as I show you later on, suggesting that is the environment, the changing environment, that also in countries with low income, they can increase the incidence of type 1 diabetes. So what is in the environment that can stimulate this increase of cases? Now, that is the incidence expressed in numbers. As you can see here, you have the Australasia, you have the high income North America here, and you have the Western Europe, as I mentioned, but with differences in Western Europe. And then here you have all the other countries with a lower incidence. Remember that the incidence around 10, 15 per 100,000 under the age of 15 was present in Europe 15 years ago. So 15 years ago, the incidence, for instance, 20 years ago, the incidence in Rome and the Lazio region was around 12 cases per 100,000 under the age of 15, 12. And now we move that Europe has around 25 new cases in 15 years. So also with the European environment of course, rich countries, you still have an increase in type 1 diabetes. That happened the same in the low-income countries. So from a pathogenic point of view, this is a very interesting question to try to understand why there is an increase that goes on either in low-income countries and in higher-income countries. And there may be an explanation that I'm going to give you later about it. Now, here you have the terrible figure of the total estimated life expectancy of a 10-year-old child diagnosed with type 1 diabetes in 2022. And as you can see here, different color as well, this is the expected age of life, less than 25 years of age. In this light orange, 25 to 39, and in gray, expected life, 40, 54. And this figure, compared to what happens in Europe, for instance, with a greater than 70 years of age, and compared to the United States, that you have an expected age range 55, 69, you see that that definitely could be due to different offers by the National Health Service in explaining the difference between countries with a higher incidence as well. Because if you have countries that have the high incidence, you think that the process of beta cell destruction is similar and the environment is similar. But then after diagnosis, some other factors came into action. That is the education of patients and the expenses that government put into treatment of patients with diabetes, with type 1 diabetes. So that figures, and looking at what's happened in Africa, for instance, and in other countries, if you look at the data in India, we have 25 to 39 expected age of patients with type 1 diabetes. So to conclude this first part of my talk, that is linked anyway to the second part, we can say that recommendation that we discuss and we say that is something that should be obtained all over the world, in particular for adolescents, is the educational attainment. Very important to do that because people have to be educated, patients have to be educated. The uninterrupted access to insulin, where possible, some blood testing strips available always for this patient, professional education, and then the healthcare reforms that in some countries taking care more and more of patients with type 1 diabetes. Always people think that type 1 diabetes is a less relevant compared to type 2 because the numbers are lower. But the number here of these patients is lower, certainly compared to type 2. But the dramatic evolution of the disease process put us in a strong position to say we need to take action immediately to promote as much as we can the assistance to patients with type 1 diabetes and avoid that they die so early. But then the second part of my talk, and this is of course the suggestion, is time to change the story, timely diagnosis, insulin strips, PAP and GCM, and prevention and cures. We go now to this problem of the novel phenotype of type 1 diabetes and obesity, and also the impact that this may have on the late complications. So what about obesity and type 1 diabetes? I'm sure that most diabetologists that work in the field of diabetes, they always think that type 1 diabetes has nothing to do with obesity. Type 1 diabetes is a disease of the same. 100 years ago, 120 years ago, when insulin came into action, right? The story was, right, the insulin is that to treat patients that have no insulin. That's it. But type 2 diabetes is another disease. It's the disease of the rich. It's the disease of the wealthy people. It's the disease of people that eat too much and the people obese. Okay, but now we have this new phenotype. What is this new phenotype of BMI above 25 and type 1 diabetes? Now, from type 1 diabetes, we have well-known factors: intensive subcutaneous insulin therapy, the avoidance of hypoglycemia, the genetic susceptibility, the hormonal alteration, the anti-influx of energy-dense food, psychological factors, and socio-demographic disparities. But if you look what happened about all that is the so-called low-grade inflammation that may occur in patients with obesity. Lipotoxicity, glucotoxicity, mitochondrial dysfunction, adipose tissue dysfunction, endocrine alteration, and the gut microbiome dysbiosis. And from there, you move to what has been well demonstrated over the years, the systemic complications. That is metabolic syndrome, the insulin resistant, the cardiovascular disease, the kidney failure, and now also the kidney and liver disease, the CKD, cardiovascular, kidney, and liver disease. And all that could be linked to this pathogenetic mechanism that accelerate beta cell apoptosis. And of course, that means that obesity-associated insulin resistance requires higher dose of insulin. So if you require a higher dose of insulin, what's happened? You put on weight. Insulin is the perfect example of how, by taking insulin and by increasing in body weight, patients with type 1 diabetes need also more insulin. They put on weight under a very physiological condition, taking more insulin and eating more. And there is also another issue that I will take care of discussing this problem of insulin that induce type 2 diabetes-like phenotype. Now, if we say that overweight and obesity is now part of patients with type 1 diabetes, well, we can say that 3 to 40% of patients with type 1 diabetes are overweight or obese. 20 years ago, 30 years ago, there was not such a phenotype. And the question is, why you have a new phenotype of type 1 diabetes? Why type 1 diabetes is changing so much, even in countries with low income, where people have access to insulin? Why is that? Now, the patients with type 1 diabetes are becoming insulin resistant. They require increased amount of insulin for treatment. And as I said, there are the enhanced risk of developing chronic complications. The whole key point is that obesity is now changing the natural history of disease over the years. Remember what happened in the US with the same famous medalists, those people that after 50 years of type 1 diabetes did not develop complications. They were always in normal body weight. They were not taking over insulin. They were having a proper education for having a perfect diet. And that was the reason why they did not develop complication. So it's lifestyle that can induce complication of this kind in patients with type 1 diabetes that resemble the complication, macrovascular complication of type 2. So at this stage, you don't have any difference between a type 1 and a type 2 diabetic patient, phenotypically and from a mechanism of action of factors responsible for inducing more and more complications. Another aspect that we think about it, what happened about the adoption of the combined technology of CGM and CSII? Patients with type 1 diabetes are very happy about it because they don't bother anymore about their diet, because they don't bother the fact that they may go into hypoglycemia or hyperglycemia. They say there is the monitor that tells what should I do and what automatically does. So now even the mothers are very happy about this system because they don't bother about children at school, because they can see the children can take more food, but then there is more insulin. More insulin, it put the situation like a normal subject. And therefore, technology could be somehow linked to this increase of body weight in patients with type 1 diabetes. Can we believe that we discussed that at the meeting, and that was very interesting. The fact that insulin itself may increase insulin, may determine an increase in body weight, and then complication associated with macrovascular complication of type 1 diabetes. And so this is the slide where all these concepts are summarized. As you can see here, on the red, moving on the right, and on the blue, moving on the left. Well, we have the weight gain due to insulin therapy. We have the intensity control of glucose that determine the weight gain because you take more insulin due to change in your diet. The destruction of the accelerated beta cell remain, because remember that some of these patients have the beta cell function still present at diagnosis, and therefore this tend to be lost within a few years. There is a chronic inflammation, and the chronic inflammation, the blue, brought here to growth hormone IGF-1 dysregulation with the enteroendocrine signaling dysregulation, and then complication that move from hypertension to chronic kidney disease to metabolic associated liver disease, metabolic syndrome, cardiovascular disease, obstructive sleep apnea. All these complications are typical of type 2 diabetes, but now this is becoming more and more typical of type 1 diabetes patients. And this is due to technology, to the new way of dealing with patients with type 1 diabetes, and of course, overlapping between type 1 and type 2 diabetes. I presented at the meeting a slide with the so-called double diabetes. Together with another speaker at the meeting, Professor Busetti, we presented a slide of 15 years ago, 16 years ago, where there was a rainbow, where type 1 and type 2 diabetes cross each other. And that was only a small percentage. But now, I think, at least in countries where the incidence is increasing, the overlap between type 1 and type 2 diabetes phenotype is the new phenotype that did not exist before, but of course, a new phenotype, but that is accompanied by different mechanisms responsible for the insurgence of this increased body weight. And I think this is something that also in low-income countries has to be taken into account. And I think that these are the consequences of the overlapping between type 1 diabetes and obesity complications. The diseases, the typical disease I mentioned before, including the PCOS, problem with fertility, or higher risk of developing endometrial cancer, kidney disease, including end-stage renal disease. So my final consideration is that obesity is a driver for the development of type 1 diabetes and LADA, latent autoimmune diabetes in adults, that we discussed, and I did not present data here, but definitely LADA is a typical example of a mix one of type 1 and type 2 diabetes. We have the increasing prevalence of obesity now well established in patients with type 1 diabetes. The problem that we have to face now, how can we manage obesity in type 1 diabetes? Because that has never been thought. Nobody's thought about treatment of obesity in type 1 diabetes. Now we have this new phenotype that deserves to be treated. And of course, the point is that we have new drugs like the GLP-1 and the SGLT2 that has been considered, but still are not authorized for use in type 1 diabetes, because these are the typical drugs to be used in type 2 diabetes. And you remember the problem that the SGLT2 induced years ago when the European Medical Agency approved their use, but after 2 years blocked the use of SGLT2 in patients with type 1 diabetes because they were having ketoacidosis, and therefore patients with type 1 diabetes cannot be prescribed SGLT2. So I think that the main message I like to leave to the audience is that the world of diabetes is changing, because the two worlds of type 1 and type 2 diabetes are now overlapping. And this is something totally new. And in the next few years, we will see more and more research going on in this direction, and more studies will be published dealing with this new population of patients with type 1 and type 2 diabetes together. Thank you. Thank you. Yeah.
Thank you so much. Over to the chairpersons.
Right. Okay. I guess I can make some questions or comments. So first of all, about the talk on the 1 hour glucose levels replacing the 2 hours. So do you plan to replace the 2 hour glucose levels with 1 hour? Or I guess a further thing that can be done is you take care of the AUC of glucose after you have given a glucose load. That would be more predictive, I guess, instead of doing just 1 hour or 2 hour values. If you can look at the AUC, the area under curve for glucose levels for 2 to 3 hours or even 4 hours, probably that would be more predictive of how your beta cells are responding to glucose, or what insulin resistance is doing to that glucose load. So what is your comment? Shifting from 2 hours to 1 hour, or probably the AUC of glucose curve after giving a glucose load would be what the future of diagnosis or treatment strategies would look like.
Right. This is an interesting question. There are different positions here. My position is that also type 1 diabetes, if you think for a moment about type 1 diabetes diagnosed under the age of 10, or type 1 diabetes diagnosed during adolescence, and type 1 diabetes diagnosed in adult age. Now, there are differences between these three types of type 1 diabetes in terms of residual beta cell function, and in terms of beta cell responding, endogenous beta cell responding to hyperglycemia that can be induced by wrong food absorption in terms of wrong diet and so on, and put on weight because you do not exercise. So the mechanisms that then are responsible for the increased body weight and obesity vary considerably among different populations. The age is important, but also the diet is important, because there are diets that definitely are inducing typical changes in terms of increased body weight, liver disease, and therefore we have to consider the cytotoxicity at liver level, and of course the increase of insulin, more or less according to the liver cytotoxicity induced by other factors associated with diet. Therefore, it is difficult to see how could be the future along this line. I think that we need to keep blood glucose levels within the normal value as much as we can. And there is what we could do with the combined technology of glucose and insulin infusion where possible. But I think this is only for countries that are rich. In general, in countries where insulin is available and you don't have this sophisticated pump, the large majority, it is difficult to intervene by blocking some of these mechanisms because children and young adults tend to eat more. And if they eat more, they put on weight and they include all the complications typical of type 2 diabetes. This is what worries me, that we don't have tools at the moment to try to modify this evolution of the disease. Because the world is having a diet all over the world, even in poor countries, that they want to have food. Whatever is coming, they want to eat. And of course, this is not what we could do with diabetes, because diabetes is a disease that needs a careful diet all the time, both in type 1 and in type 2.
Yes, another question for Dr. Paulo. Now, you mentioned about double diabetes and the use of GLP-1 receptor agonist and SGLT2. So what stops us from using a drug like metformin or pioglitazone in patients who are getting double diabetes, who are basically heading towards obesity or overweight who are type 1 diabetes? And how are the use of AGIs, the alpha glucosidase inhibitors, in patients who've got double diabetes? Metformin, pioglitazone, AGIs is what the question is. GLP-1 receptor agonist and SGLT2 are wonderful drugs, but what stops you from using metformin, pioglitazone, or AGI in these patients?
No. I think that the metformin, I didn't talk about metformin because metformin, we have 50 years, even more of data available of metformin. Metformin is a great drug, and metformin can be given and should be given and must be given to patients with type 1 diabetes that they lose weight. But still, I noticed that many doctors, young doctors, or even senior doctors, thinking about type 1 and taking metformin, they immediately think, oh, metformin, why don't we use the new drugs? Metformin was for type 2 diabetes, it's not for type 1. And that is something that is a matter of education. But clearly, I tell you that I give metformin to patients with type 1 diabetes that are obese because this is the first choice. And also pioglitazone. I give pioglitazone, I give metformin. The problem is that today we have these fantastic drugs that are GLP-1RA. And GLP-1RA definitely have an effect in losing weight. There is no question about it. But they are not authorized, they are not reimbursed. But I tell you, there are patients that buy it outside the National Health Service and they use it. Of course, it's off-label, but they lose weight and they improve their metabolic control. I'm aware of patients with these characteristics. The SGLT2, I think, is more dangerous in a way, because with the SGLT2, you tend to have blood glucose levels that goes down very fast. And if you reach glucose levels that are around 80, 90 milligram deciliter, then the patient is somehow scared that can get into hypoglycemia. And so if you get into hypoglycemia, says, well, I should not take insulin because my blood glucose is 80. And the consequence is ketoacidosis. So the SGLT2 has to be carefully evaluated. Patients well educated, I know about few patients that take an SGLT2 and are having improvement of their metabolic control and they lost weight. Also, there is the fact that why not giving SGLT2 or GLP-1 to patients with type 1 diabetes complications, with cardiovascular and kidney complications? Those patients could be definitely treated with these drugs because can have an effect in preventive death. We know that, but they're not authorized. We are working hard with the AMA in Europe and also at the NIH. I know that they are trying to work to promote the use of GLP-1RA in patients with type 1 diabetes, but still is something that is not seen very favorably by many companies. Because as you know, the worries is that with these drugs, you may get into hypoglycemia, and then somehow you don't take insulin, and then, of course, you move to ketoacidosis. So this is an area where we will work very hard in the next few years. It's a priority because we have an excellent opportunity to treat patients with type 1 diabetes and obesity with these drugs. Trials are ongoing. I know pretty well that there are good trials and we will see the results soon. Possibly the authorities can change their mind.
Thank you, Professor Paulo. That is all from my side. I'll hand it over to Dr. Vijay Bhaskar Reddy for any questions, comments that he has. Thank you.
Thank you. Professor Maria Schmidt, so what is the cutoff for 1 hour value on GTT for 1 hour value, do you have, is the same as 200 milligram per deciliter, or do you have different cutoff 1 hour value?
Yeah, the cut point for the 1 hour plasma glucose to define intermediate hyperglycemia, it's 155 milligrams per deciliter. And for diabetes, it's more than 200, it's 209 milligrams per deciliter.
Slightly higher than the 2 hour value.
Right. Both slightly higher, yeah.
We take 140 and 200. So now you're telling 1 hour is you're getting 155 for impaired glucose tolerance and 209 for diabetes diagnosis. Yes?
Right.
Okay. So another thing about the postpartum period. So what is the best screening test you would recommend at 6 weeks? You told 6 to 8 weeks. We need to call these patients and do the glucose testing. So what is the best test? Would you go for a GTT? Would you do a HbA1c? Or what would you do a fasting glucose? What is the best single test if you have to do for a diagnosis of glycemia at 6 to 8 weeks postpartum?
Right. Well, I'm glad you asked this question. There was no time to address all those issues, and I think this is a very important point. Of course, if we like to prevent diabetes, all the evidence that we have is based on people that were screened with an oral glucose tolerance test. Results for those that only had fasting glucose that was high, or in hemoglobin, glycated hemoglobin elevated, they did not find really an effect. Most of the effect that we know is based on an abnormal glucose tolerance test. But a 2-hour glucose tolerance test is quite complicated to be achieved a good percentage of women who really attend an early screening. So in this regard, as I mentioned very much the possibility of using 1 hour test, we had this year a publication showing the importance of using the 1 hour test for exactly to improve the reach of women at postpartum. So I think at this point, I would recommend the 1 hour test for this woman, rather than fasting glucose or glycated hemoglobin.
Maria, thank you very much. May I add the one point that I think it is of interest, where technology may help in this case. Now, we have completed a study where we look at CGM in ladies after partum within a year. Now, the CGM is straightforward. Give us data that 30% of women that had a condition of diabetes in pregnancy, 1/3 has high blood glucose levels 1 hour after eating. So 1/3, and we're talking about women that have been one year after partum. So I think that 1 year after partum is quite considerable amount of time, and still they have few points of high glucose levels, even around 180 milligram deciliter. We have submitted an abstract to the EASD to discuss that. And I think that the use of CGM, in particular in people at risk, is now becoming more and more a very useful tool to prevent the onset of the disease. And in this lady, I found that the lady were very happy indeed to discover that 1 year after pregnancy, they have the opportunity to use these devices and learn more about their diet and learn more about blood glucose levels after 1 year of pregnancy. Did you think about it? Did you think about doing that with a CGM?
I think this is in the list. I think it's a little bit expensive at this point to consider as an alternative for most of the women. But yes, you are absolutely right. I think this is a pretty good perspective of improving our reach of this woman.
Professor Paulo, so I'm glad that you discussed about type 1 diabetes in low-income countries because type 2 diabetes overwhelms the type 1. So type 1 diabetes is not given much importance in low-income countries. So because we are resource limited, many of our patients do not have CGM or ambulatory glucose monitoring. So how much do you think is good enough to maintain HbA1c? Suppose you are having a patient with low income countries, they're not on insulin pump, they don't have CGM. What would you think would be a reasonable HbA1c to maintain in this setup?
Which value of HbA1c, you mean?
Yes, yes.
Well, I think that definitely should be around 7%, even less than 7%, but with 7% I will be satisfied. But I think that this is an issue that varies considerably due to the fact that insulin may be available in shortage. Means don't forget that the problem is availability of insulin. In some countries, insulin is not available regularly as expected. So I think also that if you have a residual beta cell function, nobody talk about residual beta cell function. Residual beta cell function, that is C-peptide. Of course, nobody measures C-peptide in low-middle countries in patients with type 1 diabetes. But we have seen that C-peptide, if it's preserved for some time, you can take less insulin. So by taking less insulin, it's easier to keep your blood glucose under control. So my suggestion is that glycated hemoglobin can tell us a lot if there is an endogenous insulin production or not. But keep the amount of insulin need, just to look at easily, is about 0.5, 0.6 unit kilogram body weight. This is what you should try to get your patients. If you go to 1 unit kilogram body weight, I think that there are other factors from an environmental point of view that can induce this too much insulin. And too much insulin could be a problem for complication I mentioned before. And so I think that the regular amount is 0.5, 0.6, 0.7 unit kilogram body weight.
Thank you very much. Last question is, I have been finding off late that the main insulin producing companies like Eli Lilly and Novo, they are losing interest in production of insulin. They want to shift over to weight loss drugs. Is there any way you can convince them to stick on with insulin?
Well, I think this question is very relevant. I talked to some of the company, but if you think about how much do they make with GLP-1, how much should they make with insulin? So I think it's a ratio 1 to 20. So that's the problem. So companies are making money. Their priority is not to do other than making money. This is what the priority. This is what people get the money from the investors, and the investors want to get money, and therefore you will see. My feeling is that more and more you will see GLP-1, not SGLT2, but GLP-1 array getting into type 1 diabetes, because you have this new phenotype of obese type 1 diabetes. And then you will see that many companies will say, well, Lilly, Novo will say, oh, yes, we will invest in type 1 because there are patients that are obese. So that is, I'm going to expect that in 5 years from now, that will be the new phenotype of patients with type 1 diabetes. But thanks to the GLP-1 array, the world will change for them.
Thank you. Over to Dr. Pranav from Sun Pharma team. If there are no comments from Dr. Saket.
Yes. Okay. Thank you so much, sir. Thank you so much, Professor Paulo and Professor Maria, Dr. Saket, Dr. Vijay Vaskar Reddy, sir, thank you for joining us today. As we were sharing the highlights of the day 3 of the IDF conference, our heartfelt gratitude to you, and your dedication to advancing global diabetes care is really inspiring. With this meeting, we are reminded of the importance of the global collaboration and addressing the diabetes epidemic. Thank you so much, doctors, for joining us. And we would like to conclude the meeting. Thank you. Thank you.
Thank you. Thank you. All the best.
Thank
Bye-bye.
you. Thank you, Pram.
Bye-bye.
Thank you, Dr. Saket.
Record.